Good afternoon. I'm Dr. Nicole Cooper, and I'm head of healthcare policy at Lyft, where I work to expand Lyft's presence in the non-emergency medical transportation space while helping to lead the company's broader healthcare strategy. Since 2016, Lyft has worked with healthcare organizations across the country to help communities in need, including low-income individuals, the elderly, and people with disabilities to travel to health services such as chemotherapy, prenatal care, and dialysis treatment in various settings as appropriate. I have the pleasure of speaking alongside a distinguished group of healthcare leaders this afternoon and in discussing a very important topic, ensuring that there is equitable access to innovations in dialysis therapy, a topic that spans healthcare coverage and timely access to care, delivery, and therapeutic treatments for vulnerable African-American patients living with end-stage renal disease who rely on kidney dialysis treatments. According to the CDC, people living with diabetes and kidney disease are at increased risk of severe illness and even death from COVID-19. Now more than ever, we must change the way we deliver dialysis in America so that high-risk patients can remain safe and not be exposed to the virus as they receive dialysis. This topic is of increasing equitable access to kidney care is very relevant to Lyft and to our mission for two reasons. Lyft currently serves thousands of Medicare Advantage enrollees through our partnerships with various health plans across the country, including Humana, an innovative plan that will be featured in this forum this afternoon. And secondly, a sizable portion of Lyft's healthcare riders are Medicare Advantage members with ESRD, who are in need of regular rides to and from kidney dialysis treatments. Before the panelists all introduce themselves, I'd love to share that during the Q&A portion of our forum, we ask that audience members place your questions in the Q&A box and not in the chat box within your viewing windows so that your questions are not lost amongst the chatter. We want to hear from you and we welcome you to pose questions when we open things up in a bit. So let's begin and get this discussion started with Deborah speaking first from the Better Medicare Alliance, then Dr. Agarwal from Humana, followed by Guillermo from Baxter. Deborah, take it away.
Thanks, Nicole. Give me one moment. I'll present my slides to everybody. Good afternoon, everybody. I'm happy to be here today to speak about this very important topic. At Better Medicare Alliance, with our 146 ally organizations and nearly 500,000 grassroots beneficiary advocates, we work to highlight the value of Medicare Advantage. As a director of policy and research, I work on advocating for policy and doing research that ensures Medicare Advantage continues to provide high value and quality healthcare. Prior to the passage of the 21st Century Cures Act, beneficiaries who had ESRD could only enter Medicare Advantage in a very limited capacity. However, we're very happy to announce that now, starting on January 1st of 2021, ESRD beneficiaries will be able to join Medicare Advantage. So we believe that Medicare Advantage, that their cornerstones of care management and care coordination will help to slow disease progression, which is really important given that most ESRD beneficiaries don't know that they have the disease until it's too late. According to the CDC, 37 million adults in the United States have chronic kidney disease, but only 8% are actually aware that they have it. So as we get into this, I do want to give a little bit of background on ESRD and set the stage. So ESRD, or end-stage renal disease, is actually stage 5 of chronic kidney disease. The top causes of ESRD are diabetes and hypertension. 68% of people who have it are between the ages of 45 and 74. Non-Hispanic whites make up 40% of the population with ESRD, and Blacks make up the second highest racial or ethnic group with ESRD at 27%. According to the Organ Procurement and Transplant Network, there are around 100,000 people currently waiting for a kidney transplant, and that was as recent as last week. So as I previously mentioned, most beneficiaries don't realize that they have chronic kidney disease until it's too late, until they've ended up in the emergency room with either stage 4 or stage 5. So then what happens is that the average cost of care for these beneficiaries on dialysis is over $96,000. But when we look at the average cost of care for a beneficiary with ESRD who received a transplant, their care is actually around $38,000. So given the majority of these beneficiaries that they crash into ESRD, meaning they end up in the emergency room of the hospital and have to start diabetes right away, I wanted to talk a little bit about what it costs to care for these beneficiaries just within the first month of their treatment. So if a beneficiary has no comorbidities, they only have ESRD, the average cost to treat them is a little over $19,000 for the first month of dialysis. If they have ESRD and hypertension, then the average cost to treat them is actually a little over $20,000 for the first month on dialysis. And if the beneficiary has both ESRD and diabetes, then costs to treat them for dialysis and overall healthcare treatment in their first month of dialysis is actually over $21,000. It's also important to note that beneficiaries do bear some of these costs, with the average beneficiary with ESRD paying at least $10,000 per year out of pocket. Thankfully, though, CMS's final Medicare Advantage, their final rule, which came out in May of this year, is working to help to ensure that Medicare Advantage can help with some of these needs. So, for example, it expanded telehealth and network adequacy flexibilities, making it easier for ESRD beneficiaries, especially those in rural areas, to check in remotely with their nephrologist on a regular basis from the convenience of their own home. CMS also took action for home dialysis. So currently, more than 85% of Medicare fee-for-service beneficiaries who are on dialysis in center hemodialysis spend around 12 hours per week actually hooked up to a dialysis machine away from the comforts of their home. And so it's also important to note that that this is not a partisan issue, that former Obama administration CMS Administrator Andy Slavitt called home dialysis the best in standard of care. So I'm looking forward to the conversation that we're going to be having on innovation in ESRD care, especially around home dialysis and ways to care for these patients and the important role that Medicare Advantage can play.
Thank you, Deborah. Dr. Agarwal, would you like to introduce yourself?
Yes, Dr. Agarwal. I'm actually an ER physician, practice about a week in the month still. Joined Humana in 2016, really motivated around the idea of population health and the idea of Medicare Advantage members, how we can improve their care and really invest in proactive services. And shortly after joining Humana, 2 years ago, I got really involved with our kidney care strategy. Sorry, I'm just getting this ready. And have been overseeing a lot of the work we do in the kidney space. Part in how we prepare for the Cures Act, as Deborah mentioned, which we're really excited about, with ESRD beneficiaries for the first time that are on original Medicare having the option to join Medicare Advantage. And as we've started thinking through the kidney strategy, we did a lot of learnings where we met with leading nephrologists. We did patient focus groups, working in coordination with the American Association of Kidney Patients. We've met with several players, including Guillermo's company, Baxter, just really learning about what is the art of the possible and where do we need to begin. And we found a couple things that I thought were pretty interesting. Just CKD is primarily silent. As Deborah mentioned, a lot of it has to do primarily with diabetes, hypertension, comorbidities, advancing age. And 40% of patients have not actually engaged with a nephrologist by the time their kidneys have failed. So by the time they've hit stage 5 and ESRD. And as a result, what we're seeing is, for patients that are starting dialysis, almost 80% of them are what we call crashing into dialysis, meaning that, they present to the emergency room, volume overloaded, maybe some cardiac arrhythmia, and then find out that, they need emergent dialysis. And then during that hospital stay are notified of needing outpatient dialysis. And, if you think about the, 10 to 12 hours it takes a week, 3 times a week in a clinic plugged into a machine, that's a really big impact on your lifestyle. And then, recognizing that, only 10 to 12% of dialysis in the US takes place in the home. And if you look at other developed countries, neighbors to the north in Canada, 40%, you have Hong Kong, 80%, you start to recognize that, we can do much better. And so that's some of the focus. If you look on the bottom of the slide, is we really want to reduce, hospitalizations, preventable hospitalizations by 50%. We want to triple the rates of home dialysis. So we're targeting, 25, 30% by 2025. and really improve the outcomes. And this is really in line with where the industry is headed. The executive order that was signed in July of 2019 is really around slowing disease progression, increasing home dialysis and kidney transplants. We think about how we're targeting this at Humana, what the industry is saying, and it's really 4 big buckets to think about. It's really good holistic chronic care and disease management, and recognizing social determinants of health, and also some of the socioeconomic disparities that we're seeing. Really focusing on smooth transitions to those that are progressing to end stage. And smooth can mean, home dialysis. It can mean smooth into the clinic. It can mean transplant. It can mean medication, palliative type treatment. Really just the right treatment for the right member. And with that, we think we can increase patient adherence and really improve quality of life. Last thing I'll finish up on is, it's really an interesting time. There's just a lot of interest in the kidney space. It's given a rise to lots of new companies. And so this is just an example of, 6 companies that we've met and seen, and we're working with many of them. But it's an exciting time, I think, for the industry. A lot of companies are targeting this in various different angles, but really around the idea of increasing awareness and slowing disease progression down. How they do it is something that we're going to be testing at Humana. We're really interested to learn more on what the right answers are, because there's a lot involved here. Care coordination with the nephrologist, working with the member's family, accessing different challenges they might have with food insecurity, transportation. As Nicole's doing a great job, leveraging Lyft to provide rides to dialysis centers. It's 3 times a week. That's a lot you have to coordinate with. So excited about the space and everything that's happening. And I'll pass it back to Nicole. Thank you.
Thank you, Dr. Agarwal. Guillermo, we'd love to hear from you.
Yeah, thanks, Nicole, and welcome to everybody. I think today's day 1 of the 2020 National Minority Quality Forum, and it's great to be with all of you again today. I believe Keiko will bring a slide up in a moment here for me. Thank you, Keiko. And hello to Amal and Deborah as well. Nice to chat with you again. Today is a great moment as innovation and infrastructure within the kidney care market convert together. And it's great because we have these tremendous examples, like Nicole mentioned, really looking at transportation and the way that patients can go to the place that they will receive care. As Deborah mentioned, there are clear differences in terms of the cost of beneficiaries as it relates to whether or not they knew that there was something coming on the kidney care side, if there's comorbidities involved. And then lastly, as Amal described, the ability to think outside of the box and to do something different. In some cases, it means that new organizations will rise into the kidney market and do certain things that hadn't been done in the past. But at Baxter in particular, one of the things that we like to think is that we can continue to innovate alongside these payment model changes that are happening that have very well-aligned goals with what we have been attempting to do now for some time. So my role at Baxter is to lead our home dialysis business. Between our home dialysis business and our in-center dialysis business, we treat with critically necessary supplies, devices, drugs, or a large percentage of the number of beneficiaries that Deborah described. And through that responsibility, one of the things that we have been trying to do for some time now is to really take these payment model opportunities and to look at how we can align the things that we do as a supplier of products to enable those goals and to enhance the likelihood that they will actually come to fruition. And so at Baxter, as we look at 2 very specific payment model innovations that CMS has either introduced or finalized very recently, the first is around the transitional add-on payment adjustment for new and innovative equipment and supplies, which we refer to as TPNIES. And the goal of this specific payment model change is to facilitate access to new and innovative renal dialysis equipment and supplies. This becomes very important, especially when we think about our communities of color that oftentimes are either left out, left until later, or in some cases, forgotten altogether. And so as we think about the second model then, the second payment model innovation, which is around end-stage renal disease treatment choices model, this one in particular becomes very important to increase the access to home dialysis and to transplantations, which becomes very interesting when you think about the fact that a person may live a very long life only to find out that they're diabetic and ultimately their kidneys fail. And then one night they get a phone call that there is a kidney available and they have to get to the hospital within a few hours in order to prep and go into transplantation. So it's very odd about how all of the system works. And the great thing about these two models in particular is that they're really focused on increasing access to all beneficiaries. And so at Baxter, what we stepped back and did several years ago was to partner with the NAACP, where we held over 3 years, hundreds of events across all of the US, where we reached thousands of Americans to try to figure out why we needed to do things differently. We then decided that not only did we have to innovate and commercialize differently, we also had to reach these populations in a different way altogether. And so one of the first things that we did was to think about how we prepare for our products through clinical trials and to make sure that African Americans are represented at least or more than the proportion that they represent from a dialysis community standpoint. And one product and one therapy that we've just recently launched, Steranova, which is expanded hemodialysis, which really addresses several clinical factors that impact dialysis patients that go in center, was over-indexed from a development standpoint in terms of our clinical trial with African Americans participating in that trial. The second piece is, and on that bottom tile on the far right, Baxter Empowers. This is really our slogan around home dialysis, which is to exchange worry for confidence, limits for freedom, and clinic visits for something particular to, in this place, the persona, jam sessions between the grandfather and his granddaughter. And it's really to make home dialysis relevant for people of color, because one of the things that is necessary is that all people that go on home for dialysis need to be confident that they can do it, and to establish the ecosystem through learning and information to make sure that we increase the likelihood of being successful on home dialysis. So with that, I thank everybody for this opportunity. I look forward to our questions, and I'll hand it back over to Nicole to take us through a couple of questions as we get started.
Thanks, Guillermo. Deborah, I'll take it to you first, and we appreciate the overview that you provided and talking about overall the healthcare policy landscape and what has guided us to where we are today with innovation and care delivery. So ESRD beneficiaries will be able to join Medicare Advantage plans starting in 2021. And we want to know from you, what was the coverage and the treatment like for patients up to this point before that policy was changed? And what impact will the policy shift that has been made truly have for Medicare beneficiaries?
Sure. So thanks, Nicole. Prior to this change, there were 3 specific situations where a Medicare beneficiary could actually enroll or have Medicare Advantage coverage. Otherwise, they had to be in traditional fee-for-service. So they would have had to have developed ESRD once they had already been enrolled in Medicare Advantage. They would have had to already had coverage with the existing provider, so just being in the same existing provider, or they would have had to be in a chronic special needs plan. So those were the only ways that these beneficiaries could actually have access to Medicare Advantage. So we're really excited now that they're actually able to enroll in the program and that it's not just limited to those 3 categories. We really think that the care coordination and the care management that's available to these beneficiaries is extremely important, especially with on top of the out-of-pocket maximum that Medicare Advantage has to offer, and that they, you know, as I mentioned previously, they had really, the average cost for a beneficiary is $10,000 out of pocket, whereas in 2021, the Medicare Advantage out of pocket maximum is actually going to be $7,550. So there is that cost savings there to the beneficiary as well. And really hoping that, the beneficiary, I think as Amal spoke to, that their specialists are speaking to their primary care physicians, that they're being screened for CKD, so that they're not crashing into dialysis and that they have additional opportunities and options for their care.
Thanks, Deborah. Dr. Agarwal, you described several innovative partnerships in your overview presentation. Can you walk us through which partners you selected to work closest with and why, and what advances is Humana hoping for, and what gaps and benefits will you be filling through those partnerships?
Yeah, sure. So a few different parts of the question. So one, part of our partnership selection was looking at a lot of these companies and just doing some due diligence to understand how they're approaching the membership, and then also on what outcomes are they targeting, right? And so we've spoken a lot to dialysis, but when you think of CKD, there's a large volume of members, almost 85%, that are not going to progress to end stage to dialysis in a 12-month period, right? So while the focus on dialysis is important, we also need to be thinking about what we're doing with members upstream with CKD. And so looking at things like medication adjustment, medication adherence, right? Diet, nutritional support, social determinants. And then the other big piece of that is, how are you doing that, right? So is this primarily telephonic? Are you going to have a nurse in person? Are you going to be coordinating with a nephrologist? So all these things really helped us decide who we want to work with. And upon this discovery, what we also realized is no one's really figured this space out yet. And to pick maybe one or two companies to do this nationwide would be challenging, because even if you figured out the model, to scale something is going to be difficult. And we really feel health is local. And so part of our strategy was really partnering with companies that had a good model, that were also going to states or locations where they were already present and knew the nephrologists, the PCPs, and some of the demographics well enough. So that really helped us. And then what we're measuring is some of those same things I spoke to is, how often are you reaching out to a member? How are you reaching out to the member? Is there, what type of medications are being adjusted? How often? And then analytics, how are you looking at that? How are you identifying risk for, ER use, admits? So all those things have really put together our strategy. And so in the slide I shown, I think we've partnered with 5 or 6 companies to date, and we're going to be testing them out over the next couple of years. And in addition, we're also staying, very close to the incumbents in the space and the technology that's coming. So I think Guillermo will talk a little bit about their advances in PD, which we're really excited to see. And then there's also, CVS and Outset that have home hemodialysis capabilities that are also very excited as they're getting proficient in the market to be working closely with.
Wonderful. Guillermo, you talked about recent innovations that have had substantial and positive effects on kidney care in the US. What is Baxter doing and contributing to enable that positive shift?
Yeah, I'll tell you, there's a couple of great things that are happening. So first of all, the fact that these payment models are being introduced and finalized is a great change. What makes it even better is if there's partners, suppliers, and products to actually enable the goals of those payment models to actually succeed, which is a very important thing, because oftentimes when you look at, well, why didn't this demonstration act work, or why didn't this payment model actually achieve its goals? It's because maybe there was a part of the formula, the ecosystem, that wasn't quite ready. And I really feel in this case that the community has been preparing for this moment for some time, and I believe that we're ready. And so at Baxter in particular, one of the things that we said is we have to change the way that we think. We have to change the way that we act. And ultimately, it just needs to be an innate way that we just behave, in terms of making sure that in particular that we are reaching communities of color with our products and our services and our capabilities. That product that I mentioned to you a moment ago that we recently launched, Theranova, it's a dialyzer. And this dialyzer does some new and creative things that no dialyzer has been able to do in the past, which is why the FDA granted it de novo status. What's important about that in particular is that the very first customer, the very first nephrologist, the very first patient in the US that will use that dialyzer was on the south side of Chicago, purchased by a Black nephrologist for a Black community with Black nurses. And this is what we mean by doing things differently at Baxter, is making sure that every single community has access to our innovation and to our products, and that those products are designed in a way that can support and enable the success of these innovative payment models, because the more that we do to contribute to that, the more likely it is that we'll continue to innovate in this space. And this space is long overdue for some innovation. And so it's great to hear all of the different examples of partnerships and payment model changes, but the entire formula, the entire ecosystem needs to be set up in such a way that every part supports the other. And if we do that well, I feel very confident that next time we speak, we'll be talking about some very positive results.
That's great. Deborah, ESRD beneficiaries have more complex healthcare needs that often result in higher costs to the Medicare system, which all the panelists have discussed today. When you compare patients who have Medicare coverage who are more complex compared to the average beneficiary. So what are some innovative solutions that you've worked on or that you specifically recommend that would address this challenge, both for health plans and for care delivery?
Yeah, so thanks for speaking about this. I think it has come up, as you mentioned, a few times about the expense that it takes to care for these beneficiaries. They just happen to be much more complex patients. Medicare Advantage is really well suited to care for complex patients with the care management, the care coordination, supplemental benefits such as transportation, like what Lyft provides. Medically tailored meals are also available to a lot of beneficiaries. And so it's working to address not only the disease, but the whole person. And so any of the other comorbidities that exist. And so we're talking about, as I mentioned, that care coordination piece where your primary care physician is working with your nephrologist and your endocrinologist and your cardiologist and your care manager. And your care manager says, hey, did you know that you can, you have this transportation benefit so that people aren't avoiding going to dialysis if they need to, or having their food delivered to them. So, do you know that actually someone will pay, like your health plan pays to take you to the local grocery store. And here are some really healthy foods that I think will work for you for your disease. It's really important. And we're really encouraged to see that a lot of plans are offering these benefits. It goes up every year with supplemental benefits being offered. President Trump, this has been touched on a little bit, his advancing kidney care, American Kidney Care executive order is also really important. The new ESRD treatment choices model that came out, it was just announced earlier or at the end of last month. While it isn't fee for service, we're still really excited about it. It's encouraging that innovation. It's encouraging the use of in-home dialysis. It's encouraging live donor transplants and things like that. And so the more innovation there is in this space, the better it'll be to care for these beneficiaries and hopefully bring some of the costs down. That being said, we think it's really important for beneficiaries to find out before they crash into the ER. And having that earlier diagnosis, whether it be you're seeing your primary care physician on a more regular basis, or when you go once a year, once every 3 years, they run the test that needs to be run. And beneficiaries need to be educated as well. If you're a diabetic, you need to understand that you're now more at risk for having ESRD. If you have hypertension, same thing. It's important to make sure that these beneficiaries are educated and understand what it means for them. It's also really important for Medicare Advantage plans to be paid the same amount. We put out a white paper earlier this year that showed that in Texas, for example, the rate of payment is the same in both Dallas and Houston, but given the penetration, it actually doesn't make up for enough. So Houston actually has to make up the difference, the 9% that they are missing for the benchmark rate. So it's really important that, whereas in Dallas, they're not. So Dallas actually makes more than that. So they're able to actually do something else with those funds and give them back to the beneficiaries. So it's really important that the payment is made accurately as well to be able to encourage the supplemental benefits like transportation and meal and things of that nature.
Thank you, Deborah. Before I pose two more moderated questions to our esteemed panelists, I just want to reiterate to all of the virtual attendees that we do welcome your questions in an open Q&A forum, and that we welcome you to actually place questions into the Q&A box and not the chat box within your window with Zoom. So Dr. Agarwal, you mentioned that 90% of people with chronic kidney disease are unaware that they have it. And Deborah, you also mentioned that the Better Medicare Alliance has released similar data around really a shockingly high statistic. So as a physician, Dr. Agarwal, can you expand on the complexity of this issue, and can you expand on what can be done to address it? and what Humana specifically is already doing to increase diagnoses, treatment, and quality of life outcomes for these vulnerable patient populations?
Yeah, sure. I think that's a great question. You're right. I mean, there's a huge prevalence of, CKD and lack of awareness. And what do we do about that from the industry? There's, as a physician, I see that regularly. And, before I got really involved in the kidney strategy, working in the ER, CKD was not something I really watched out or looked out for. I was more worried about the acute kidney injury. And, even in my own patient experiences, is taking this role. I had a patient encounter, African-American, came in, had a chemical in his eye from work, was able to irrigate that out. But while doing it, noticed that his blood pressure was running really high and started talking to him about blood pressure and asked him, have you always had high blood pressure? Yes. Okay. Have you seek treatment? No, I haven't. Have you heard of, dialysis? Yes. I have some family members on dialysis, but I don't need dialysis yet. That was the key word, yet. So it's changing the paradigm. I asked, what do you mean by yet? Because you may not ever need dialysis. Why do you think that's in your future? He's like, well, I've seen family members on it, but I think I'm, far away from it. I'm like, listen, we can figure this out. So, did some blood work and then brought that to his attention that, hey, it looks like your GFR would put you in stage 3. Now, part of the challenge with CKD though, is to officially diagnose CKD, you need 2 compromised lab values 90 days apart, basically because you want to take away the chance of being acute kidney injury. And so I think that's where we see a little bit of challenge with calling something chronic versus acute, because we may not have access to someone's previous medical record, right? We don't know what their kidney function normally looks like. And so we don't call it CKD as much as we should. And this is one of the more important reasons for getting more primary care engagement and having a nephrology engagement, but having that care coordination. And then also, maybe this is out of the scope of our conversation, but access to medical records for the individual so they can see their blood work and take ownership of what's going on. But, one of the things, so, we partner with the National Kidney Foundation, their CMO, Dr. Vasiludi, and I, so we co-authored a piece for emergency room docs saying, we have to start creating awareness and we have to start reaching out and letting our members know that they have compromised kidneys when we see them and call it out. 2, with our analytics. Now we have, lots of patients that get regular lab values. A BMP is done at every annual physical, which gives your kidney function. So we are specifically targeting members that may have compromised GFR, but not a diagnosis for CKD, and reaching out to them to get more information and make sure they're coordinated, reaching out to the primary care doctors and saying, hey, have you addressed this? Because this hasn't been diagnosed. And are we managing this the best we can? Do we need a nephrologist? So we're looking at not just diagnoses, but labs, predictive analytics, to understand who's going to progress, to create that awareness. And then the last piece, and I think we've spoken a little bit about payment models, but re-incentivizing the payments so that you are being reimbursed more for good proactive CKD care and recognition, and not just the dialysis piece, right? So reconfiguring the the nephrology payment component. So these are just a couple of ways that we're trying to do that.
Great, thank you. Another reminder to our virtual attendees, again, we welcome you to insert various questions that you have on your mind that you'd like the panelists to address in the Q&A box. So Guillermo, I'd like to go back to what you were discussing. And as it relates to what you mentioned earlier about the end-stage renal disease treatment choices models, what must the kidney community do exactly to deliver excellent dialysis care at home? Can you break it down for us?
Yeah, I'll try. And if I get this right, then, there's much bigger and better things I think ahead for me and for Baxter, because this has been a tough one to crack for some time. And so the ETC model and the incentives that are included in there is a great next step. Okay, but that's not enough, because now it takes all of us really working together to do a couple of key things. And one is probably a little bit more important than the others, but let me just run through them very quickly. As Amal said, we've got to identify at-risk Americans sooner. And so whether it's through primary care, whether it's through family history, and understanding patterns through family history. I mean, this is a disease that, you can actually start to think about, well, if my aunt and my grandmother and so on and so forth had some sort of kidney care that was required, I may want to keep a closer eye on this. And so identifying those at-risk Americans is incredibly important about this, as mentioned, with so many patients who crash into dialysis, where some delayed onset could have been done through earlier and proper management of CKD, as Amal mentioned. The second is, once those people are identified, we have to educate better and more fairly. And by better, I mean, there really has to be more robust education on all the forms of care. So prevention, delaying, diet, better management across comorbidities, all of these things really are a combination. And it's not that each person needs every single one of those, it's to understand which person needs which one of those the most right now, and going into that. And then also, as part of the education, is if dialysis is going to have to happen, to make sure that the treatment options are shared fairly and early enough for the person to really take a role in making the decision on what should happen next. So that's part two. Part three is to really plan for the next step before the current step is taken. So that's to think about the progression of things. Okay, so today we're going to try to manage your CKD and we're going to delay the onset, but the next step is going to be this. And so this is what we need to start to do to prepare for that in the event that it happens. That sort of cohesion today will make the management and the transition of a patient smoother in the future, because the shift from one aspect of their therapy or their disease state to the next should not necessarily be a failure. If done for the right reasons and at the right time, it could actually be considered a success. And because that person was transitioned without complications to the next stage because it was the right time to do that. And the fourth piece, and the one that I want to see happen more, is just to try more. Try more for home dialysis. Let a person walk in and treat them fairly and say, you know what? Until I have a reason why you can't do this, we're going to try to do this. Because the alternative is to go in center, which is a great option for many patients, but it shouldn't be the only option for 90% of Americans. And that, for me, is the one, and for us at Baxter, is the one that we want to try to enable the most, because we can contribute to all of those parts as a supplier and partner to the dialysis community, to the providers, to the nephrologists, to the nurses, to the families who are going through this. But at the same time, that last one about just try more is something that we really want to do. We really want to enable through all that we do. And so you're going to see Baxter do a great deal here to enable and support education on the reimbursement side. The partnerships that Amal described, many of those organizations are collaborators with Baxter as well. And that's really where I believe the community is coming together, because I think folks are seeing that this is something that we can actually do together if we just try more.
Thank you, Guillermo. So we're starting to get virtual attendee questions, so please continue to share them. The very first question that was posed early on in our panel actually addresses many of the topics that you just discussed, Guillermo, with patient populations of all backgrounds and all kinds being ripe, if you will, to begin receiving home dialysis care. So one attendee in particular, and I'm teasing out some of the details here, what was shared, has a sister who was recently diagnosed with renal cancer in New York City. She did receive bilateral nephrectomies, treatment that she's received since the COVID crisis has hit New York City. She's now on home dialysis, hemodialysis 3 times a week, and she's very eager to begin home dialysis if it's an option for her. So recognizing this is not a forum where we are providing medical advice, but can you just talk at a high level around the types of patients and the characteristics, if you will, for patients who may most be eligible, or the best case study, if you will, to receive home dialysis? And perhaps that's a question for Dr. Agarwal as well.
Yeah, Amal, how about I take it just the basic English version of the answer, and then you can enhance it with some of the medical terms. Yeah, so there's actually very few contraindications for peritoneal dialysis in particular. That's the most common form of home dialysis therapy that occurs today. The second most common is home hemodialysis. So basically similar to what you would do in center 3 times a week, just administered almost in a self-care model at home. So peritoneal dialysis is different than hemodialysis in the fact that you're doing it 7 times a week. So most patients do it 7 times a week. They do a nightly exchange of 8 to 12 liters of fluid. It goes into your peritoneum, it's basically your tummy. It filters out all the bad stuff and leaves a little bit of fluid in you throughout the day so that you can go throughout your day, have a pretty decent diet. Everybody's got to watch their salts and the sugars, things like that. It doesn't change. There's a majority of folks with very few contraindications, unless you have some sort of abdominal issue that you can't work around. But as long as you can get access to the peritoneum and there isn't some other complicating factor, most patients can attempt peritoneal dialysis. Again, the great thing of the model that we have today is the model actually allows for people to try a therapy, and if it doesn't work out, to transition to another therapy. Some provider groups do it, I think, a little bit differently than others and enable that sort of transition, I think, a little bit more consistently. Our job at Baxter is to make sure that when a patient calls and says, or when a provider calls and says, we have a person who's ready to try peritoneal dialysis, that we give them every option to succeed on peritoneal dialysis, whether it's the intake process, the welcoming process, the home delivery supplies process, the training process. All of it is tailored to enable consistent success for each person that transitions into peritoneal dialysis. So Amal, maybe you can add a little bit more about the medical side.
Yeah, no, I think you're spot on. And the way, and I'll caveat this is I'm not a nephrologist and haven't prescribed dialysis, but, my understanding, is consistent, is that unless you're told otherwise, everyone should at least be evaluated and really viewed as a candidate for home dialysis. There's lots of things that come into appropriate candidate for home dialysis. One is, any medical contraindications, which Guillermo touched on. And then 2, just around, as you learn about home dialysis, is this something you're willing and ready to take on? Do you have caregiver support? Do you need caregiver support, right? And what's your living environment like? And is your caregiver okay, or if you have a spouse, okay with the equipment that's going to be required? And so there's other things to look into it, but just seeing 10%, knowing that you can get up to 80% like you are in Hong Kong, there's a huge room for opportunity here. So, I would almost push for every patient to ask for home dialysis and to find out why they're not a candidate, if they're not, but if they are, to really push to get home dialysis if that's something that they would want.
Nicole, I would add, this isn't quite for this situation, but similar to what's being said, is health literacy needs to be kept in mind to making sure that everybody has access. Not everybody understands what a nephrologist is, what dialysis is. So making sure that it's explained in a way that people can understand it, and really making sure that they understand that they have these options, that in-center isn't their only option. I think because it's so common, people just sort of always think, oh, I can just go in-center, and it's making sure that that in-home dialysis is explained to people in a manner that they can understand, because they're not clinicians.
And Deborah, can we pick up there? That was certainly a theme of this forum from all 3 of you all speaking as experts, that enrollee, patient, member education is at the heart of ensuring that proper access to care and proper treatment is ultimately rendered, and ultimately that these diseases are slow in their progression. So can you talk a little bit about what you know around Medicare beneficiary education around these issues along the thread that you were just speaking on?
Sure. So there is some beneficiary education in Medicare around ESRD, especially once somebody's been diagnosed. There are programmatic requirements in place. I think, though, what really needs to be worked on is making sure that it's not just beneficiaries who have CKD before they end up with ESRD. It's really, again, it's going back to the comorbidities and making sure that people understand, okay, now that you have this, given certain conditions, you're more at risk now for ESRD and what that means. It's also, again, if you're in a chronic special needs plan and Medicare Advantage, it's making sure that you really understand what your options are. It's also having care managers, nurses, nurses assistants, that sort of thing, reaching out and saying, hey, I want to talk to you about this. And so you understand, you have diabetes. And so here's what that means. It means you have to watch what you eat, not just for your insulin, but also, again, as was mentioned, your salt and things like that, to ensure that the kidneys are sort of, looked out for, so that to slow that progression, or really essentially hope that there isn't that progression. But again, it needs to be done in a health literacy way and in a culturally appropriate manner. If you're looking at, depending on where you are, you need to make sure that the people who are having the conversations, if it's face to face, that they look similar, that they have similar, if English is a second language, that they speak that second language or the first language, and it's not just a straight, translation, that the phrasing that's used makes sense. And so it's really important to get the education piece right, and those are some of the ways to do it.
Great. Another question that's come in is around the role of telehealth. Can you all actually speak to what you see as the various components of telehealth, especially as it's been accelerated with the COVID-19 pandemic and people having to shelter in place around the globe? Can you talk about how telehealth is enabling proper care for kidney care for Medicare beneficiaries?
Yeah, sure. I mean, I can jump in. I think telehealth is a phenomenal channel, and one I'm really excited to see being used a lot. We saw a lot of adoption. Even pre-COVID, I think 5.5% of baby boomers were using telehealth, which is accelerated a ton in just looking at the claims from March through May. And as Seema Verma said from CMS, we've seen so much adoption, it'd be silly to go back, so we should make this permanent. So I think telehealth is definitely an avenue we should be using and leveraging, especially when you think about transportation and mobility issues. Why not offer the telehealth? But I also don't think telehealth will completely replace, in-person visits, but I think it can help with that. And then when I think of home dialysis, I think of telehealth as a great opportunity for someone at home dialysis to connect with their nephrologist or their dialysis nurse, even during a treatment, and make sure everything is working as it should. And then also for regular checkups, they can do that. So I absolutely think telehealth has a strong position.
And it's showing up quite a bit already. And
yeah.
So for our peritoneal dialysis community, there's tens of thousands of people utilizing this on an annual basis already across the globe, and growing very rapidly in the United States. We have a product that is called ShareSource that actually enables two-way management, where the patient can transmit key clinical factors around fluid adequacy, therapy adequacy, just a simple measure of, did the therapy happen, to the clinician. The clinician can then respond with something to the device that enables for a correction or an expansion of something that was attempted clinically, leading up to that observation and that insight. And so this happens on a daily basis, and there's thousands of nurses using this technology already in the United States, carrying on for thousands of patients, with thousands of nephrologists prescribing it. And so this alone is not going to solve it, but it supplements and enhances the great care that's already being provided, because it allows for people to, I would say, address one very specific concern that a lot of clinicians have as it relates to sending patients home, is that I'm not going to see this person now on a weekly basis. You don't need to see them to know that they're doing the right thing. There are very specific reasons why it's important to see a person from a clinical standpoint, and a lot of that can be done very similarly to how we are conversing today. It's not the only way, but it is something that helps address some of the initial concerns that folks have as it relates to sending a patient like this home. As we mentioned, these patients have comorbidities. In some cases, they are a little bit more ill than most people. And so being able to enhance that care and supplement the great policies and procedures that are already out there by many of the dialysis providers in a way that allows for the clinicians to enhance their confidence to send the patient home is a great thing for all. And so I see a lot of advancement in that technology. And then also, as it relates to the advancement of the technology, what's going to make it even better is that now we're starting to see the convergence of technologies to be able to create a more homogeneous platform that provides a greater visibility and more access on a timely basis to treatment records and to information that will enable an improvement on therapy over time.
Thank you for that, Guillermo.
Yeah, so telehealth is, as we all know, is very important, especially given COVID. We put out a study on telehealth and utilization in Medicare Advantage earlier this year as well. And one of the things that's important to note is availability in plans. So it's something that's available in Medicare Advantage, generally a little bit more freely than in the fee-for-service side. And in 2021, actually, about 94% of Medicare beneficiaries will be offered some sort of non-health related supplemental benefit, including telehealth. So that's really important. It's really big access. One of the things that we need to keep in mind is rural versus urban, right? So a lot of times beneficiaries in rural areas, they don't have the ability to do two-way audio video. So they can't see their doctor, but they can certainly have a phone call with them. Also, some seniors we've seen in some of our polling, they don't particularly like videos. They worry about, what does my house look like? What my doctor's gonna think, oh, I have to get dressed. I haven't gotten my hair done. I haven't put my makeup on. So video may not be the best option, but audio certainly is. And so it's really important to keep all of that in mind when we're talking about telehealth. But it's still certainly, given what's going on, and this population is really at risk for COVID, especially being seniors, ESRD being a comorbidity potentially, and to really make sure and offer these beneficiaries the opportunity to still meet with their providers and have conversations and have their questions answered.
Great, thank you, Deborah. And in the spirit of innovation, health equity, social determinants of health, all topics that we've been discussing this afternoon, are any of you all seeing an increase in the use of Z codes to document, track, and monitor social determinants of health that greatly impact kidney disease and other comorbidities? These are all questions from our Q&A box in the Zoom.
So I can go first. We don't see claims here. We're not a health plan, but I do know that in the beginning of the year, there was not a lot of use of Z codes. They weren't as commonly utilized as they had been, but I would think and I would hope that that's something that is starting to increase now, given, if the provider is having that two-way audio video, they can see in the house, oh, that maybe it's in disarray, or maybe this person is food insecure and things of that nature. So that it might be a little bit easier to have that conversation when you're not in a sterile clinical environment, but it's really the doctor seeing me in my house. I feel a little bit more comfortable with them.
Deborah, would you mind taking 20 seconds to explain what Z codes are?
Sure, absolutely. So Z codes are, they're CPT codes, so current procedural technology codes that are specific to social determinants of health. So they're issued by the American Medical Association, I believe, and they can be submitted on the claim from the doctor to the insurer. So it essentially ends up on the record, the beneficiary's record with the insurer. It also ends up in the EMR to sort of help provide a little bit more information around some of these things, such as not having access to food, so food insecurity, or homelessness, or things of that nature.
And having inadequate access to transportation. I had to insert that from the standpoint of Lyft Healthcare. Dr. Agarwal, did you also want to take this question?
Yeah, I was going to mention that that's a really good question. I'm going to actually look back and see if we've seen adoption in claims. I can't speak to that if we have, but I know what we've done as a company is really try to find that information out. And so we use, data from the Robert Woods Foundation, but we also do our own assessments where we send a nurse practitioner into the home to learn about the member, learn what comorbidities they have, but also document, what they're living like and other challenges they might have. And we've also we did a unique study in Florida with a primary care group where we embedded asking questions about food insecurity as part of their H&P and visit with a member, and found that, a number of patients tested positive or screened positive for, basically having to decide between prescriptions and food. And then we're able to locate them with food banks. So there's just a lot of opportunity here. So I think, I'll look into and find out about Z codes, but proactively, we're also trying to identify some of these challenges. And, Deborah, you hinted around on the telehealth question. we also saw that there might be an interest, but not everyone has Wi-Fi or a device. And so we're also looking at, that gives you a whole new sense of information, and trying to send, a powered device like an iPad that has, WebEx or Zoom on it for your doctor's appointment. So you click on it, you can have your appointment and ship it back. So just a lot of things we're uncovering.
Thank you for that, Dr. Agarwal.
I would add to that. So we did hear in our telehealth project that there are providers out there who are doing exactly that. So they are going to the beneficiary's house saying, here's a tablet. The beneficiary can then have their video conference, and then they say, okay, thanks. They take it back, they sanitize it, and then they give it to the next one. So that when there are these access issues, there are still ways to make sure that the beneficiaries are getting the care that they need.
Great. And Dr. Agarwal, if you wouldn't mind taking perhaps 30 seconds to make the tie between some of the examples that you provided here today around how Humana is enabling proper care, proper kidney care. Can you tie that into Humana's National Bold Goal work? I had the pleasure of working on the Bold Goal team at Humana about 5 years ago, and thinking about how the company would be approaching measuring its impact that you all have been seeing for the last 5 years. So I'd love for you to at least touch on that point here.
Oh, yeah, no, thanks for bringing that up. Yeah, I mean, Bold Goal has been a phenomenal effort. Started out, I think in 2014 or 2015, but the goal was improve our members' health by 20% by 2020. And the way we were measuring that was by unhealthy days. And so it's a call-in survey, and ask members, in the past 30 days, how many days have you felt unhealthy? And that could be physical and mental, and capturing that, and then following up, as various points to see if we're impacting that. And lots of different ways to do it. But one realized this is not, if you're really going to improve someone's healthy days, you can't target just Humana members. You have to target the community. And so we build these Bold Goal communities in several markets. I believe we're at 9 markets, where we work with several stakeholders across the community to really increase community awareness and access to resources for all members, not just Humana. And we've seen a lot of good feedback and results. And just given the conversation of the topic for today, I did reach out to the Bold Goal team, and they shared some stats. And our Black Humana MA members experienced 16.08 unhealthy days, compared to 12 unhealthy days experienced by our white Humana members, right? And this was a 2019 data. So that's 4 days difference, just 1 day a week now. Imagine being more unhealthy feeling than someone else. So huge opportunities here, and definitely areas we're looking to work with the Bold Goal more proactively as well. But thank you for bringing that up. Yeah, that was great.
Thank you. And I want to thank you all of our virtual attendees, for joining us this afternoon. We've heard some terrific points from our panelists from various points of view. Deborah, you shared some extensive insight on the complex health policy landscape that's guided care. Dr. Agarwal, you've certainly talked about care delivery, and you've illustrated for us what's happening from a large health plan that's trying to go upstream to help patients with CKD. And Guillermo, you have discussed 2 recent shifts that are creating buzz, so to speak, within the kidney care and dialysis market, and told us how that is really impacting the products and the services that you're providing for vulnerable patients across the country. So I want to thank you all for participating and for having an engaging session today. And I hope that everyone, all of our virtual attendees, continues to enjoy the various sessions that are sponsored by the National Minority Quality Forum as part of this annual summit on health disparities. So with that, I'd like to close us out and wish you all well. Take care.
Thank you.
Thank you.